Sexuality, its expression and intimacy remains important throughout the lifespan of a woman and hence needs to be well understood in health as well as in illness. Sexuality contributes to some of the most complex aspects of human behavior. Sexual dysfunction is more prevalent in women than men. Prevalent studies of female sexual dysfunction, FSD, are confounded by a lack of consistent methodology. Classification and determination of FSD are complicated by variability in levels of normal sexual function and the importance of sexual function to individuals and cultural beliefs. Community studies indicate that the prevalence of female sexual dysfunction ranges from 25 to 63%. An important population-based study, a sub-study of the National Health and Social Life Survey, was conducted in 1992. It provides a probability sample among 1,749 women and 1,410 men living in the USA, aged 18 to 59 years, and is based on face-to-face interviews conducted by trained interviewers. The population was matched for age, education level and marital status. Following are the ranges of dysfunctions across the age groups. Lack of interest in sex, 27 to 32%. Unable to achieve orgasm, 22 to 28%. Pain during sex, 8 to 21%. Sex not pleasurable, 17 to 27%. Comparable prevalence rates were calculated by Hayes et al. From 11 published prevalence studies that included assessment of all FSDs. Similar results have been reported by another population-based telephone survey of women aged 30 to 70 years to ascertain prevalence of FSD using the validated profile of female sexual function and personal distress scale instruments. Women's sexuality can be associated with personal, physical, social, and cultural factors. Therefore, sexual problems may be associated with significant distress, including a low self-esteem, a reduction in life satisfaction, and a decline in the quality of the relationship with her partner. It is estimated that more than 600,000 hysterectomies, an average of more than one per minute, are performed in the United States per annum. Amongst other concerns with hysterectomy is the possible effect of the surgery on woman's sexual response. In the United Kingdom, 33 to 46% of women report decreased sexual response after hysterectomy. With oophorectomy, although sexual problems are highly prevalent, a very small proportion of women consult a physician. These include benign conditions such as menometrorrhagia, uterine fibroids, leiomyoma, adenomyosis, endometriosis, pelvic pain, and for actual and possible malignancies, total removal of uterus and cervix, subtotal, supracervical removal of uterus, with or without unilateral or bilateral oophorectomy. Various reasons have been described for reduction in sexual response following a hysterectomy, including hormonal changes, psychological factors, and anatomical factors. Common hormones produced by the ovaries include estrogen, progesterone, and testosterone. Women who have had bilateral oophorectomy lose most of their ability to produce the hormones estrogen and progesterone, and lose about half of their ability to produce testosterone, and subsequently enter what is known as surgical menopause, as opposed to normal menopause, which occurs naturally in women as part of the aging process. In natural menopause, the ovaries generally continue to produce low levels of hormones, especially androgens, even after menopause. These symptoms are commonly addressed through hormone therapy, utilizing various forms of estrogen, testosterone, progesterone, or a combination. There is paucity of consistent evidence to draw a conclusion as to the effect on sexuality of oophorectomy with or without hormone replacement therapy, HRT. Almost half the papers do not specify whether HRT was administered. Other papers report that some of the women in their study received oophorectomy, and some received HRT but contingent Relationships are not specified between hysterectomy with or without oophorectomy and its impact on sexuality. However, the available data shows no significant difference in changes in women's perception of their sexual functioning has been reported before and after hysterectomy based on whether the women had their ovaries conserved or removed, with or without receiving hormone replacement therapy. Anatomical factors include the lack of the uterine contractions, which in some women are an important aspect of orgasm. Scar tissue preventing expansion of vagina, which may make intercourse difficult. Scarring or nerve damage causing discomfort and interference with feeling sexual pleasure. Reduced quantity of tissue resulting in diminished vasocongestion may reduce sexual arousal and the probability of multiple orgasms, and also the disruption of vaginal blood flow, local nerve supply and anatomical relationships, which could have a negative effect on overall pelvic floor function. In addition to these factors, the pathology for which the hysterectomy is performed may differentially affect sexual response. It has been reported that women who had a hysterectomy due to endometriosis reported more difficulty and less satisfaction with orgasm than women who had a hysterectomy for other reasons. There is considerable evidence that simple abdominal hysterectomy does not have an adverse effect on pelvic organ function, bladder, bowel and sexual. Evidence-based review of effects of hysterectomy on sexuality. Hysterectomy is the most frequently performed gynecological operation. Therefore, the myths regarding hysterectomy need to be dispelled, and women requiring hysterectomy should be counseled using the best available evidence. Simple hysterectomy, total abdominal, TAH. Subtotal abdominal, STH, and vaginal hysterectomy, VH. Farrell and Kieser performed a systematic review of sexuality after hysterectomy and found that research in this area was largely retrospective without the use of validated outcome measures. Most studies showed either no change or enhancement of sexuality following hysterectomy. Theoretically, hysterectomy should increase sexual pleasure by removing the fear of pregnancy, relieving dyspareunia and uterine disease, particularly cancer. Russis et al. Performed a retrospective study to assess the patient's own appraisal of their sexual responsiveness after hysterectomy, 61 TAH, 22 STAH, 42 VH, and found that sexuality did not diminish after any type of hysterectomy. Alexander et al. Performed a prospective randomized trial comparing hysterectomy with endometrial ablation using validated measures of psychological and sexual function both pre- and post-operatively. They found no difference in post-operative sexuality after 12 months. Differences in libido and sexual sensitivity following various types of hysterectomies have been evaluated. Y over 6 months, found a reduction in sexual problems VH, TAH. Or STA. A large prospective study. Women who were interviewed with validated questionnaire preoperatively and at 6, 12, 18 and 24 months after hysterectomy for benign condition, and found significant increase in frequency of sexual activity, a decrease in dyspareunia and a reduction in low libido. Overall, this study found substantial improvements in sexual function after hysterectomy. It has been hypothesized that the disturbance of innervation of cervix and upper vagina after total hysterectomy interferes with lubrication and orgasm. Other factors that might contribute to sexual problems include a reduction in cervical mucus and vaginal shortening. However, Weber et al. Do not agree with these views. Highlighted the influence of anatomical changes by comparing coital frequency, dyspareunia, libido and frequency of orgasm before and at 6 weeks, 6 months and 1 year in 105 women with TAH and 107 with STAH. Both groups showed an equal but slight reduction in coital frequency and dyspareunia, with statistically significant deterioration after STAH. The frequency of orgasm was significantly reduced in TAH group but not in STAH group. However, two randomized studies by Thakkar et al. And Zabi et al. Found no difference in frequency of intercourse or orgasm between TAH and STAH. However, there was a significant increase in frequency of intercourse and decrease in dyspareunia after hysterectomy. Current evidence suggests that dyspareunia reduces after hysterectomy. Sexual function does not usually deteriorate after a simple hysterectomy, although a few women may develop sexual problems. There does not appear to be a difference in sexual function in women who have STAH and TAH. Radical hysterectomy, RH. Women after surgery for genital cancer have to deal with not only the fear and anxiety generated by the diagnosis, treatment, and prognosis, but also with the constant fear of recurrence. These women are often unaware of the consequences of the operation on sexual function. Although there is extensive evidence in the literature that shows adverse sexual functioning after treatment for cervical cancer, most studies report on heterogeneous groups of patients undergoing surgery, radiotherapy, or both primary or adjuvant. Radiotherapy has been reported to result in more severe sexual difficulties than hysterectomy alone. Patients treated with radical hysterectomy alone seem to regain their full sexual capacity and satisfaction more frequently. Bergman et al. Compared 256 women who had been treated for early cervical cancer and 350 controls. They found that treatment of cervical cancer caused changes in vaginal anatomy and had negative effect on sexual function. These changes included decreased lubrication and reduction in perceived vaginal length and elasticity during intercourse. However, the difference in the two groups with respect to frequency of intercourse, orgasmic frequency, and pleasure were small. Grumman et al. Prospectively compared 18 patients with stage 1B cervical cancer undergoing RH with 20 women undergoing hysterectomy for a benign cause over 8 months using standardized questionnaires. The cancer patients showed slightly better sexual function preoperatively than the other group, but this deteriorated with time. Sexual function among patients with benign disease showed steady improvement, indicating that RH for stage 1B cervical cancer is not associated with major disruption in sexual function. However, this study had a small sample size, so must be interpreted with caution. A large prospective study comparing 173 patients who had RH with age-matched controls indicated that RH had a persistent and negative impact on patients' sexual function, whereas majority of vaginal problems disappear over time. Moss et al. Objectively assessed sexual arousal in women who had RH, TAH and 17 age-matched controls by measuring vaginal blood flow during sexual arousal using erotic films. The authors suggested that although RH appears to be associated with a disturbed blood flow after sexual response, larger studies are needed for confirmation. Overall, however, while RH affects some aspects of female sexuality, the majority appears to be transient and may be influenced by other overriding issues related to the diagnosis of cancer. Laparoscopic hysterectomy. A prospective case control study found no alteration of sexual function in premenopausal women undergoing either conventional or single-port laparoscopic assisted vaginal hysterectomy. Sarati et al. Found that laparoscopic radical hysterectomy did not show any benefit on women's sexuality over the open abdominal surgery for cervical cancer. With recent advances in robotic surgery, this modality has been used for hysterectomy, benign and radical Laparoscopic robotic-assisted radical hysterectomy with nerve-sparing technique for bowel and bladder is proposed to be an attractive surgical approach for early invasive cervical cancer. However, effect on sexuality has not been studied to date and needs further exploration. Conducted a randomized trial of 135 women for benign conditions with a 2-year follow-up. Sexual functioning and quality of life variables were measured with a telephone and clinic interviews. Both groups reported improvement in most measures of sexual functioning. RCT. No statistical difference was found between the two groups before and after surgery. The frequency of intercourse, desire for intercourse, orgasm, and initiation of intercourse did not differ significantly between the groups. There was also a significant increase in the frequency of intercourse in both groups after surgery. Deep dyspareunia was reduced significantly in both groups at 12 months, but there was no statistical difference between groups. Conducted a randomized trial of 319 women with a 1-year follow-up and found no statistical difference between the two intervention groups regarding frequency of sexual desire, intercourse, masturbation, and orgasm, as well as quality of orgasm, vaginal lubrication, or satisfaction with sexual life. Dyspareunia decreased significantly in both groups, 89 women pre-surgery and 22 post-surgery. A multivariate logistic regression analysis identified preoperative satisfaction with sexual life, good relationship with partner, chronic disease, and use of hormone therapy as significant predictors of postoperative satisfaction with sexual life. Flory et al. Conducted a randomized trial of 63 women with a 7-month follow-up. There were no differences in sexual functioning overall. Gives a summary of findings reported in the papers regarding the variably reported outcomes of hysterectomy. Any individual study reporting on at least some women who experienced deleterious effects after hysterectomy, whether or not statistically significant, was included in the last column of the table. Undesirable effects on it is important to identify and report incidents of deleterious effects of hysterectomy on any individuals, since very few papers elaborated on these deleterious effects. We could not distinguish whether the women who, for example, experienced dyspareunia after hysterectomy developed this condition after the surgery or if the condition was present preoperatively but not treated with surgery. Conclusion. The research on the effect of hysterectomy on sexual function that has been performed to date is not conclusive. There are discrepancies in the literature as to whether hysterectomy improves or attenuates sexuality. Hysterectomy may alleviate the discomfort of pain and bleeding, resulting in positive psychological factors such as elimination of anxiety over unwanted pregnancy and cancer risk. Symptom relief may have led to increased sexual enjoyment and increased orgasm frequency. While women report an improvement of sexual functioning after hysterectomy, this may be the result of the relief of symptoms such as vaginal bleeding and dyspareunia from the uterus. Some women develop sexual dysfunction as a result of hysterectomy. More research is needed to clarify the issue of the effect of hysterectomy on sexual response.